Chapter 4, Wrist and Hand. Ultrasound-guided carpal tunnel release, a more typical case. Conflicts of interest. I'm a stockholder with Sonex Health, co-editor of a textbook on MSK ultrasound, and a lecturer with Expert Education. Introduction. This case is a more typical ultrasound-guided carpal tunnel release, although each case that we do is a little bit different. We start by finding the median nerve in the middle of the forearm, more toward the distal forearm, and it's indicated by the arrow here. Note that it's round, and this is normal for this particular patient. And notice the honeycomb pattern of the nerve. We then follow the nerve down toward the wrist. You'll notice that the nerve is swelling, and we are losing the honeycomb pattern. And we stop this recording right about at the level of the lunate. In the next video, we can see the nerve entering into the canal, and notice that it becomes compressed. On the right-hand side, up here, we can see an artery. This is not usually here, but it's not uncommon to see an extension of the radial artery going into the thenar eminence area. In this area, we are seeing the trapezium, and then more proximally, we see the tendon of the flexor carpi radialis going over the scaphoid and then onto the trapezium here. On the ulnar side, we can see the ulnar artery and nerve, and at the very end, we see the hook of the hamate. So we have a very wide safe zone in which to operate. As the nerve exits the canal, it reswells and goes back to its larger dimensions, larger than normal. Here we see the motor branch will be emerging where the nerve starts to split up into its various branches. And we'll see it come around the corner of the thenar muscles there. Here's another view of the splitting of the nerve, and again, the motor nerve taking off and then wrapping around the lip of the thenar muscles there. Then the other nerve we need to worry about is the third common digital. Here we see it crossing the flexor tendons of the long finger. And we want this crossing to occur down in the hand, not underneath the transverse carpal ligament. And we can tell we're down in the hand because we can see the adductor of the thumb coming off the third metacarpal here. Here's a long axis view of the nerve coming underneath the transverse carpal ligament there, and at the end we can see the motor branch ascending to go around the muscles of the thenar eminence. Here we see the ulnar artery going out, and then we can pick it up out here. It's negative on Doppler, but the superficial palmar arch is here, and we want it to be distal to our transverse carpal ligament so that it's not in any danger of being cut out here, and we can see that it's distal. Our entry point in the long axis of the arm is going to be over the lunate. And in the short axis, we want to be between the median nerve and the ulnar artery. You can see this is a very wide safe zone. So our entry is going to be between these two structures, but closer to the nerve so that we can travel into the hand parallel to the nerve. Here we're injecting the subcutaneous tissue with lidocaine that contains some epinephrine so that we get a local vasoconstriction. And here we're putting a little bit of that lidocaine with epinephrine, just a little underneath the forearm fascia. Then we switch to a 22 gauge needle, and we're using the same entry point, but we're going in the long axis of the arm and injecting a little bit of lidocaine as we go, and we want to be parallel to that nerve as we enter the hand. Here we see checking our hydrodissection in long and then short axis so that we are injecting our lidocaine in this area between nerve and artery. Then we complete our hydrodissection with lidocaine without epinephrine. If you use epinephrine, the numbness tends to last for about 12 hours, which some patients find irritating. So for dissecting in the hand, I use lidocaine without epinephrine. And here we're checking our hydrodissection in the short axis to make sure that it does not endanger any of our essential structures. Another helpful thing is to inject the ligament itself, because there may be some pain when the ligament is cut otherwise. Also, the hydrodissection inside the ligament softens the ligament and makes it a little easier to cut. Make a small transverse incision in the dermis and then use blunt dissection through the subcutaneous fat, and then through a small hole in the deep fascia we can place tenotomy scissors and cut the fascia. And then through that defect we can place a uterine dilator to be sure that we have a free path underneath the ligament, and use a freer elevator to be sure that the soft tissue is freed up from the undersurface of the transverse carpal ligament. Then we insert the knife manufactured by Sonex, and here we see the tip of the knife. This is for dissecting, and the actual blade is here, and we want to cut from here proximally. Here you can see the knife, and you can see the median nerve wants to crawl out onto the cutting surface of the knife. What we try to do is produce a situation where the knife is tightly applied to the undersurface of the ligament. By blowing up the balloons and rotating ulnarward with the device, we can block the nerve from that cutting surface. And here is our initial cut. You can see it looks like a shark fin, and we cut from distal to proximal. And then we can place the uterine dilator back in and check how we've done with our cut. And you'll notice that there's still a few fibers out here at the distal end of the ligament that need to be cut. So the process is repeated very quickly. It just takes a few seconds to cut those final fibers. And then we can do a final check of the motor branch as it comes around the thenar muscles here. In this case, the nerve was so big, I wondered if it might be a vessel, so I did a Doppler on it, but it is definitely nerve. Also, when the procedure is done, usually the motor branch has not been put to sleep by your lidocaine because of its position on a more radial part of the median nerve and coming out. Often, before you leave the operating room, you can test the function of the motor branch. And this is where the motor branch is. You can see it's quite thick. So thank you for watching our video. For more interesting cases, you can consult our textbook seen in the lower left-hand corner or the QR code in the lower right-hand corner.